Hello, everyone, and welcome to the CLL Society's Ask Me Anything. I'm honored to be your host today. I'm Michele Nadeem-Baker, a CLL reporter, advocate, co-founder of Kicking Cancer in Heels, and like many of you watching, I am also a CLL patient. I'd love to welcome my co-host, Dr. Skarbnik. Thank you for being with us, and would love for you to please tell our audience a bit about yourself.
Sure thing. Thank you so much for the invitation to the CLL Society. I'm Alan Skarbnik. I am the director of the Lymphoma and CLL program at the Novant Health Cancer Institute in North Carolina. I've been working solely with CLL and lymphoma for the better part of the last decade. I've been a member of the medical advisory board for the CLL Society, and I am very happy to participate in this and answer questions. And I thank you for the work of the CLL Society, of you, Michele, as a patient advocate. It's always great to be working together with the patients and their advocates to further the field and improve their lives.
Well, it's a pleasure to be here with you today, Doctor. We have so many questions that have been sent in, and we thank those of you who sent them in who are watching us today. And we have more questions coming in live through our Q&A. And if you have any questions, for those of you in the audience, please go to the Q&A button at the bottom of your screen and send them in. And we'll get to as many as we can today. So let's start out, Doctor, talking about treatments and testing. This is, of course, what we all want to know as patients, is what's happening out there and the best for us. So are there any CLL treatments that you expect to be FDA approved next or in the near future?
Well, this is a very good question. There's a number of new treatments in the horizon, like treatments that are not at all approved yet. And there are treatments, there are combinations of things that we already have that may be approved in the near future. So what people are looking at now, I mean, one of our goals is to minimize duration of treatment for patients, there are side effects associated with that, and also financial toxicity. So Amplify is being presented at ASH this year as an example of one of many trials being presented, which is looking in the fixed duration combination of acalabrutinib with venetoclax with or without obinutuzumab. So the top results seem very positive, and hopefully those combinations will be approved in the near future. There are studies with BTK degraders, which is a different way to tackle BTK, and they've been seen in patients who receive BTK inhibitors, and the drug is not working anymore. So instead of blocking the molecule, these drugs degrade, they destroy the molecule itself. So that's an exciting area of study in CLL. There are studies with bispecific antibodies as well. There are studies with other cellular therapies. We know the CAR T cell was approved this year for the treatment of CLL. So very exciting new things. We always wait for the annual meeting of this American Society of Hematology to know what's going to come next. So hopefully by January we have a better grasp of what's going on.
Well, we look forward to learning more about those. And do you think that degraders are on the horizon of being approved already, or is there more work to be done?
No, there's going to be more work, but that's kind of what I'm waiting to be approved in the next couple of years. That's kind of the next in line that we're really excited about.
I'm excited to learn about all these as well. What tests are available to determine a complete remission in CLL leukemia with 100% certainty?
Okay. I tell my patients nothing is 100%, right? I mean, we can never be 100% sure of anything. So there are the definition of complete remission that are defined by the IWCLL 2018 criteria, which is recovery of the blood counts to normal levels. If lymph nodes, there are no lymph nodes that are larger than 1.5 centimeters on a scan, and in a bone marrow biopsy, there's no evidence of CLL. There's no lymphocyte nodules in the bone marrow and things like that. So that's the definition of complete remission. Now, we tend to go a step further in clinical studies right now, which is checking for minimal residual disease or measurable residual disease, because this test only goes so far. And we look at a molecular level if we can capture the presence of CLL cells at the level that the test can capture. So the deeper test we have commercially available right now is what's called next generation sequencing. People may call it clonoSEQ. It's done via Adaptive as a company. It can be done in the blood. It can be done in the bone marrow. And the test captures 1 cell in 1,000,000 cells. So if we'll evaluate 1,000,000 cells with next generation sequencing, that test is able to capture a single abnormal CLL cell. But if there's 1 in 10 million, that test won't be able to capture. So that's the level of detection. That would be the most reliable testing to show full remission.
So if my testing comes back, and it isn't clonoSEQ, but my testing comes back that I am extremely close to undetectable minimal residual disease, but that initial testing through my blood, or perhaps a traditional bone marrow biopsy result, is not at UMRD, do I still request clonoSEQ?
You're talking about other forms of testing MRD because it's either multicolor full cytometry or PCR or next generation sequencing. Those other tests have a lower threshold level. It's general 1 to the 10 to the minus 4. So it's 1 in 100,000 cells. I'm sorry, 1 in 10,000 cells that test takes. So the detection level is a little lower. It depends what you're using this for. The trials that have been reported for the past couple of years have used 10 to the minus 4 as the threshold of MRD detectability. The newer trials are going further. We know that 10 to the minus, not undetectable at 10 to the minus 4 in the bone marrow is a very good endpoint for measurable residual disease. We know, but bone marrows are painful, bothersome. It's a procedure. Not everyone wants to do it multiple times.
They're not fun.
They're not fun.
I can attest to that.
We don't want to keep doing that for patients as well. So we can test it in the blood. In the blood, if there is 10 to the minus 5 in the blood, which next generation sequencing is able to get, it does correlate to 10 to the minus 4 in the bone marrow. It's an easy test. It's commercially available. It's covered by most insurances, to be sincere. So if someone is looking at that level of testing, that's the best we have right now. But I want to remind that, and this is kind of like nitpicking here, but there may be patients that the lymph nodes are a little larger than 1.5 centimeters because sometimes they may never come back to the normal size if they were too large to start with. Doesn't necessarily mean there's active disease there. It's just a criteria that with the consensus criteria, but you can have, that will be called a partial remission. You can still have undetectable MRD in the blood and in the bone marrow with that. So, we have to take those things a little bit in stride. And I don't know, the person who was asking that question, we need to understand what the goal of determining remission is, right? I mean, if you are on a continuous therapy with a BTK inhibitor, for instance, most patients have partial remission and do quite well. For many years, the disease is controlled. So not necessarily complete remission is the goal. It depends on what we're doing.
So speaking of MRD negativity and complete remission or not, we have another question is, would you recommend prolonging Venetoclax and obinutuzumab treatment to better ensure testing MRD negative?
Okay, that's a controversial question. I think is a discussion I have with every patient. Um, to put things in perspective here, uh, the study that looked at venetoclax obinutuzumab is called CLL-14. It was designed to treat 12 cycles. It's 6 cycles of obinutuzumab and 12 cycles total of therapy with the venetoclax for everyone, and it was not what we call MRD guided. So there's no continuation of treatment in the study beyond the fixed duration time point if MRD was detectable at the end of treatment. They tested actually at 3 months after the end of 12 cycles. And we did see that patients, 70% of patients, give or take, had undetectable MRD at the end of treatment. So it's a pretty good chunk there in the study. Of the 30%, they're left, the people who had earlier progression of disease were the patients who had MRD detectable at the end of treatment. Now, that didn't mean that these patients needed treatment at progression. I mean, it goes to the same kind of paradigm as we have with active surveillance. I hate calling it watch and wait, by the way. I don't like the name. I think you're waiting for something bad to happen. It doesn't necessarily ring true. I mean, I have many patients for decades being monitored.
So what do you prefer other than?
Active surveillance. I think active surveillance is a better term. A number of other doctors feel the same way. You know, we are surveilling you. We know what we're doing. You know what you're doing as a patient. You know, we know what to do if something happens, but we're not waiting for something to happen. I think just the wait part is just like, you know, you're waiting for something bad to happen. I think it's like, I mean, to me, psychologically, it makes a difference. But at any rate, the paradigm is the same. We're surveilling the disease until it gets to the point where criteria met for treatment to be indicated again. Now, having said that, this is a multi-layered question here. So give me a little latitude here because it's controversial.
Will do.
I think it's not. It is not for everyone. My take on it: when we looked at the study, most patients who had undetectable MRD at the end of treatment had it at 7 months, like right after obinutuzumab was over. The patients who were tested at that time point and still had detectable MRD at 7 months with additional treatment to the end of the study as it was designed, 50% of those patients had a decrease in their MRD and or became undetectable, and the rest is either stable or was going up. Right. So I think one single time point, it's hard to say. If we're going to look at MRD at the end of treatment and we're going to discuss with the patient, should we continue or not, we should have that time point before as well. So usually what I do with patients who are interested in that, I check at 7 cycles, I check at 12. At 7, if it's negative, it's likely to be negative at 12 as well. But if it was positive at 7 and it's still positive at 12, I'm looking at the trend, right? If the trend is going down and patients are almost there, I have a discussion, say, hey, perhaps we should continue venetoclax for a couple more months and see where we get. If the trend is stable or is going up, I don't believe additional therapy at that point will be beneficial, actually, because we're seeing where the disease is going. So it's a discussion I have with the patients. It's not necessarily for everyone. The data is questionable on that. This is a controversial kind of approach, and is a discussion you should have with your physician. You know, if it's the frontline therapy, if it's the first line therapy, most people do really well with 12 months of therapy and then monitor afterwards. And we know we can retreat those patients with the same regimen if the disease comes back. So there's that opportunity for that as well.
So I'm going to take a break for a second on venetoclax and obinutuzumab, which we have a lot of questions about, but let's go back a bit in that some of our viewers are asking things such as what would be indications for treatment, never mind the treatment, but what, to just go back to some basics here.
Okay.
how do you know as a doctor that it's time for one of your patients to start treatment?
That's a phenomenal question. So there are the IWCLL 2018 criteria, which help us identify who would most likely benefit from treatment at that time. Now, having said that, it doesn't mean that if those criteria are met, that treatment is mandatory. At that point, treatment may be beneficial. It's the minimum that we need to say you should receive treatment in general, or to have a treatment discussion. There are some criteria that are more clear cut, and we should treat, and there are some criteria that like, okay, we can have a discussion. So the criteria are if your lymphocyte count is doubling in less than 6 months or increasing more than 50% over 2 months, if you have rapidly fast growing lymph nodes, if you have any very large lymph nodes, namely more than 10 centimeters in size, which is 3.5 inches, give or take, for people who are not familiar with the metric system. If you have a very large spleen, so it's usually 7 centimeters below the rib cage. If you have a very large liver, if you have symptomatic involvement of any organ, if you have pleural effusion or accumulation of fluid around the lungs because of CLL, if you have symptomatic skin infiltration because of CLL, for instance, if you have autoimmune destruction of your platelets or your hemoglobin because of the CLL, and this is not responsive to steroids, if you have progressive anemia, generally we use a cutoff of 10 grams per deciliter of the hemoglobin to consider treatment, or if you have progressive thrombocytopenia, which is your platelets dropping, generally use 100 as the cutoff there, or if you have what I call B symptoms, severe fatigue that's attributable to the CLL. So it's just not like I'm feeling down. It's like you really, are not as functional as you were before. If you have drenching night sweats that happen most nights for at least a month, fevers that are unexplained and happens most days for at least 3 weeks, or weight loss that's unexpected of more than 10% of your base weight within 6 months. The symptoms, I think, are clear cut. People who are having drenching night sweats for a month, they are symptomatic from the disease. I think that those should be treated. Now, is there a difference in someone who has a hemoglobin at 10.1 and someone who has a hemoglobin at 9.9? Not really. So, if patients are asymptomatic and it's taking a long time to get there, and there is some hesitancy about treatment, we sit tight and we continue with the surveillance, knowing that the time for treatment may be coming up soon. So those are not, oh, it happened, you have to get treatment, but it needs to, at least some of these things or one of the things happen for us to consider treatment in the first place.
And I know it's always for doctors, there's so many variables, right, for CLL to determine. Now, regarding night sweats, someone had mentioned in the questions that they have them all day long. And they're wondering if that counts as night sweats when they have them like 24/7. Or is that something else when it's during the day? I know personally, I had them, it seemed all the time, but also it's kind of hard to determine when you're of a certain age in life between what's happening. Are they hot flashes and night sweats? Or are they just night sweats, but they're more than nighttime? Is it possible?
It is. Now you have to exclude other possibilities, right? Particularly, in perimenopausal women, are they hot flashes or are they actual sweats? Yes, the sweats can happen during the day. It is at nighttime. It's a little more specific of this. It's just because of the regulation of your internal thermostat that happens with inflammation, and that drives to that because your body temperature should drop at nighttime. So that's kind of why this becomes a little more specific. But yes, it can happen at daytime. If it is at that point, generally that's not the only symptom. Uh, People are tired, right? You are seeing a change in their blood counts that's significant, or lymph nodes are growing, or your LDH is going up. I mean, usually that you start seeing that happening too. So usually that doesn't come alone, in my experience. But yes, they can happen during the day too.
Okay. Uh, we have so many questions. Thank you all for sending them in, and those of you who sent them in ahead of time. So getting back to some of the treatments, we have a lot of questions about Calquence and how long you need to stay on Calquence and how long it takes to kick in and it gets you to UMRD is one of the questions. So I know
Okay.
that's going to be a bit of a complicated answer from you.
Okay, so Calquence and all the BTK inhibitors as a single agent, or even in particular Calquence when combined with obinutuzumab, that's the only one that had a study. Well, it's approved like that. Ibrahim had a study with obinutuzumab too, but that combination was a little different. Nevertheless, any BTK inhibitor, so there'll be ibrutinib, acalabrutinib, so Imbruvica, Calquence, or Brukinsa, they, as single agents, they were studied in a continuous fashion. So it was treatment until either progression of disease or intolerability. So side effects are too much and people could not take it. And the reason for it is that the molecule they inhibit, BTK, is recycled on a daily basis in the cellular level. So you need this continuous inhibition of the molecule to prevent the cells from proliferating. We need to look at uh, uh, um, how does medications work. So BTK inhibitors in general, they are what we call anti-proliferative medications. So they're preventing, some cells are dying, but largely they're preventing the cells from making more cells, on a continuous basis. We know that removing that inhibition allows the cells to regain that capability. As single agents, most of the BTK inhibitors do not lead to undetectable MRD, do not lead to complete responses either. They lead mostly to partial responses in most people. And that's one of the reasons why they should be taken continuously. Now, having said that, I do have patients who are on Calquence or Imbruvica or whatever one of these medications for a number of years. They are with very good control of disease. They have complete response or near that, and the patients are either requesting a treatment holiday because they have some side effects and they want to be off of it. It's not wrong to do it. It's not impossible to do it. It is a discussion that each patient needs to have with their doctor, but knowing how their disease is behaving. It cannot be a blanket recommendation for everyone. Um, it's reasonable to have that discussion. It is expected that they will need to be retreated at some point in the not too distant future because of disease recurrence. But I've had patients who had control of disease for a year or two after they stopped those medications because of not disease progression, because of other issues. So it's possible. It's not recommended. I hope that answers the question.
Thank you, doctor. Getting back to venetoclax and obinutuzumab, there are many questions about this particular protocol. And one is, does the decision to change to ven and obin depend on initial prognosticators, such as 17p deletion?
The decision to start that treatment,
They said change. They're not, I
that would be a very
don't know if
specific
they have,
question.
they
Yeah.
don't mention, I guess, perhaps this other one is from them that perhaps they're on a acalabrutinib currently.
Okay. I would let me break it down in two different ways right now then. At the baseline, patients who have not received any treatment, when we are deciding between BTK, acala, Xanu, or ibrutinib versus venetoclax or obinutuzumab, one is a continuous therapy, the other one is a 1 year therapy. Some of the things we take into consideration are the prognostic markers, namely 17p deletion, T53 mutation, what we call complex karyotype, which is if there are multiple chromosome abnormalities, usually a cutoff of at least 5. That's an ever-changing goal, a goalpost there. Those this is a CLL with a higher risk of progression, a higher chance of not achieving undetectable MRD at the end of treatment with a fixed duration therapy. For those patients, my personal preference is to use a continuous BTK inhibitor because it seems we can have a longer control of disease with that, but you need to continue on therapy for a longer time. So that's the downside of that. But also absolutely correct if patients want to, or doctors want to treat with venetoclax or obinutuzumab. That is my preference based on what we have with the data so far. Now, for someone who is on a BTK inhibitor and has a 17p deletion, I would not change to a different treatment unless there's progression of disease. I mean, if the disease is controlled and is being treated, it's not getting worse. I don't see a reason to burn the bridge and go to another therapy. We'll go to another therapy when it's necessary, meaning there is progression and patients don't need treatment. That's when we will change.
Okay. More questions on Ven and Obin. Should I be concerned if some lymph nodes on the throat are still palpable following completion of obinutuzumab along with venetoclax timed treatment protocol? And I know before you had mentioned on that sometimes lymph nodes are a lot higher than 1.5, but what about if they're palpable? Is that something that someone should be concerned about following treatment?
That's a very single patient specific question, I guess. It's hard to determine. I mean, it depends what palpable is. There are lymph nodes that are 1 centimeter and they're going to be palpable too. It depends. Are you a thin person? Depends where it is. Like here, if you're a thin person, lymph nodes can be easily palpable here, even if they're below 1.5 centimeters. The 1.5 centimeters in me, I wouldn't be able to feel it probably. So, I think it depends on a lot of things. How large was this lymph node to start with? I mean, did it shrink? Do you have a 5 centimeter lymph node to start with, and now you have a 1.8 centimeter lymph node? That's a tremendous response, right? And as I said before, even that will be considered partial response doesn't mean you necessarily have MRD positivity. As long as the things went in the right direction, there is a potential for you to have still residual disease at the end of treatment with venetoclax or obinutuzumab. And it may take years for that disease to progress after discontinuation to the point that someone will need treatment again. So that's very specific to each case. It's very hard to answer that question without knowing the entirety of the process.
No more questions. What are the benefits and detriments of the various dose levels of ibrutinib? And what factors create a change in dosage recommendation? So I know that sometimes patients are cut back to half doses or perhaps down by a third of BTK inhibitors. So I think this is based on that.
Okay. The initiation dose of any of the BTK inhibitors should be the study dose, so the full dose. I do believe that starting at a low dose and trying to go up is not the right approach. Having said that, for patients who have side effects on the medications, there are guidelines on how to change the dose if needed, and we can do it without significant detriment to the efficacy of those drugs. So if someone is on ibrutinib, to the questioning point, they can, if they have side effects and they hold the drug and the side effects come back after they resume the drug, yes, the indication is to decrease one step in the dose. So, if they're for 20, go to 280, and if they're 280, go to 140. Doses are not based on weight, so they're doses for everyone. So it's okay to decrease if there are reasons to decrease the dose. If there are no reasons to decrease the dose in terms of side effects, I wouldn't change it. We'll go with the dose that was studied and was efficacious. There was a study back in the day when I started using BTK inhibitors, looking at decreasing the dose irrespective of that, and yeah, patients remained with efficacy for a while. We do know, however, with BTK inhibitors, if you have a prolonged interruption in the first year of treatment, that does decrease your out, that does deteriorate your outcomes. I mean, the disease tends to progress a little earlier. It's okay to decrease if needed. I think that's the bottom line.
Okay. Can you explain the value of seeing a CLL specialist before treatment is needed?
Mm-hmm. So CLL, it's a disease with a lot of variables. It's a very heterogeneous disease, meaning there's very different presentations, right? There is cytogenetic abnormalities that come into play. There is patient comorbidities like other diseases that come into play. There are certain ways to look at the data, as we discussed before, that come into play. And each patient is a different person, and what's important for the patient, for their families, what's their lifestyle, things like that should come into play as well. But it's a disease that has a lot of data, and even though it's the most common blood cancer, most physicians who are general oncologists and who are very smart people and great physicians, they end up not seeing that many during the year in comparison to things that are more common, like colon cancer, breast cancer, lung cancer, prostate cancer, etc. So a CLL specialist, we're very restricted in what we do and what we see, and we tend to be on top of things that are in development, sometimes that have not even been published yet. But also we are on top, and we're the people who studied like the nitty gritty of it, the question of changing the dose, for instance, or the question of looking at MRD, or which treatment is better than, maybe better than the other for a particular patient. So I think it's important to have the opinion of people who mostly do CLL, particularly because it's a disease that generally you have time to do that. Like, it's not something that generally you need an urgent therapy, like an aggressive lymphoma or an acute leukemia, for instance. You have the time to go to see a second opinion and see a physician who specializes in that. CLL Society has a program to provide a virtual consultation for free to patients who don't have access to a CLL expert. So it's a good tool. I think for any disease, I mean, it's good to see an expert, not only CLL.
Absolutely. And that's what I found, having gone first to a generalist and then to a CLL specialist. The differences were, they were outstanding in the case of seeing a specialist. There's just so many nuances to this disease.
Yeah, absolutely. Thanks for sharing that on the patient side. Yeah.
So we have a few questions regarding immunity and once you're done with treatment. And some of them, perhaps you can give one answer if I combine a few of them. One has to do with when you reach minimal residual disease, is your immunity better and you're off of treatment? The other has to do with being when you're on treatment, is your immunity further I guess challenged would be the best way to put it. So I know we only have about 27 minutes left, and I just want to combine as much as we can here.
Okay. That's a difficult question. I don't believe MRD and immunity necessarily have a correlation there. I mean, I think if your disease, most of the time, if your disease is under control and you had an immune disruption because of the disease itself, you will improve over time. But it has the other side too. So it depends on the initial presentation before treatment started. Actually, to be sincere, there's a number of patients who are presenting with multiple infections because the CLL is depressing the immune system. They have low IgG levels. They have what's called hypogammaglobulinemia. They may require intravenous immunoglobulin, which is just a replenishment of antibodies for their immune system. The CLL can cause that, and lots of times treating the CLL will reconstitute their immune system to some extent, where the things do get better. Now, on the other hand, patients who have a somewhat intact immune system to start with and go under treatment, lots of times we depress that immune system because of the treatment. I mean, all the treatments for CLL, they are immunosuppressive. The CLL affects cells of the immune system themselves. They are B cells. They're the cells that produce the antibodies that we use to fight mainly viral infections, but other infections as well. So the treatments are all immunosuppressive, all of them. We do know that the anti-CD20 antibodies are more immunosuppressive. So obinutuzumab in particular is very immunosuppressive. So regimens that contain that may depress the immune system a little bit more. But being on a continuous BTK inhibitor, for instance, for years, rather than stopping the treatment with venetoclax or the may impair the immune system for a more prolonged period of time. But this is very variable. As I said before, this is a heterogeneous disease. It's really going to depend on the patient, the CLL presentation, how the disease is going, and how that's affecting each one's immune system. As a blanket recommendation, we do say to patients, even patients who are not in treatment, patients who are diagnosed with CLL, this is the first thing I discuss with my patients. When they come in and they're not going into treatment, we are in active surveillance, like everyone asks, what can I do? Right? What can I do to prevent problems, to make my life better? What can you do is keep your vaccinations up to date, see a dermatologist every year because 20% of patients with CLL have skin cancer. It does increase the risk for skin cancer and other cancers. So keep all your screenings up to date because it is an immunosuppressive disease. Any immunosuppressive condition does increase the risk of cancers, but particularly now melanoma skin cancer in CLL patients is a higher risk. So you should see a dermatologist at least once a year to do a skin check. Keep your vaccinations up to date. That's the best recommendation we can give.
We've had a few questions regarding, is there still a need, speaking of immunity, is still a need to wear masks in public or masks even when you're at home and you have grandkids around? So what do you think about that? It is a pain in the neck. I know that I have to confess, I still at times will wear a mask. It all depends on the situation.
I think you answered the question. It's hard to say. I mean, listen, we lived years pre-pandemic where no one was wearing a mask anywhere, and flu was out there, RSV was out there, all these other diseases were out there, and people did okay. Yes, patients with CLL or other cancers will get infections and we'll treat it. As anything, it is harder, particularly in CLL patients. It takes a little longer to shake off a cold, for instance. But people they took planes, they did their things without necessarily wearing masks. Okay, they will wear masks to go to a rock concert or something like that. And then we were hit with the pandemic, and certainly during the height of the pandemic, where we didn't know what to do with COVID, we didn't have vaccinations, we didn't have pre-exposure prophylaxis. COVID was very virulent, and people were really, really dying all the time from that. Absolutely, everyone should wear a mask all the time, CLL or not CLL. I mean, we had to control it. I think right now we're in a different situation. Yes, COVID is out there. Yes, it's still a risk. It's not as high a risk as it was in 2020, 2021, even beginning of 2022. The risk is lower. People who are contracting the COVID are not getting as sick. as we were before. The virus has changed. People are vaccinated. But you want to prevent it, yes, wear a mask. I think it depends on a lot of personal choice here. Trust me, it's a question I have all the time in the office, and it's a very hard question to answer. You know, I think it's a lot of common sense. If you're going to a place that you have zero control and there's a lot of people and you are concerned, wear a mask. You're going on a flight, wear a mask. It's fine. If you're going to visit your family and you can ask them, hey, is anyone feeling sick here? And you have some control of the situation. I don't think it's necessary. Sure, your grandkid who's 2 years old is not going to tell you if they're sick or not. And I have kids and I know how that works. But if there's no visible signs of anything and you want your grandkid to see your face, please let them see your face. Wash your hands, use hand sanitizer. Personally, I don't think it's a big problem, but it's very situational, as you posted, Michelle. I mean, that's my personal opinion.
And I concur with your opinion, doctor.
Hey, thank you.
Not that that matters.
Yeah, no, it absolutely does.
But yes, yeah, I'm about to meet friends who flew in from out of town, and I have to take a check on how they are and their sniffle factor,
Yeah,
when we go out to lunch today. So,
yeah.
someone is, a lot of people here are asking if there is anything else they can do to boost immunity. Are there any supplements? What do you suggest on that?
Not that we really know. I mean, I think that's the best answer I can get. I think integrative medicine, what we used to call alternative medicine, the name is gone, is integrative medicine. I mean, we're doing things that are not necessarily allopathic or drugs or things like that. There are supplements that can help in a number of different things that may be well studied. I think consulting with an integrative medicine specialist is always a good idea. A lot of cancer centers have that. We have that. Every time a patient has a question about supplements, I refer to my integrative medicine colleagues. They are experts in supplements. They have pharmacists who are expert in supplements. They will look into the medications the patients are receiving if they are being treated for CLL to make sure there's no interactions and there's no detriment to what they're receiving. So I think is a specialty that really helps out in that. Now, having a single supplement, they're going to say, hey, this is going to boost your immune system. To my knowledge, I don't think we have anything like that. But, there's people who like to take turmeric for anti-inflammation. I really have no problem in that, although it may increase the risk of bleeding a little bit. So be careful with BTK inhibitors, for instance. There was some questions about green tea and CLL in the past. Many studies were done. Really doesn't seem to pan out in terms of it kind of any benefit. In fact, the doses they saw that were needed for green tea in the lab to have any kind of a cellular effect were super high. It would be too much caffeine for anyone. So, short answer, I don't think so. But, I think it's a good idea to see an integrative medicine specialist to discuss those questions.
Uh, there's just so many questions. We need 4 hours, I think, and I'm thanking the audience on this. I just want to let the audience know that we will be having, the CLL Society will be having another program on December 13th that will be talking about immunity. So a lot of them that you have here will be answered then, but we're going to try to get through as many as we can here. So since you're speaking about supplements, there was a question on vitamin D and CLL, and that there's an Israeli study that came out talking about that vitamin D could help stave off treatment. So first of all, do you agree with these results? And secondly, what is the maximum vitamin D level that's acceptable? I know in the study it ranged from, I believe, 400 to 600 was the average, but the recommendation, I think, is 600 if you're under 70 and 800 IUs if you're over 70. But first of all, What about vitamin D, doctor, and CLL? Does it do anything?
We don't know for sure. I think it goes same thing with the other thing. Vitamin D is the most touted supplement of all times. I mean, if you go into PubMed and do a search for vitamin D, you're going to have hundreds and hundreds of studies. There's a number of studies there's a number of evidence that came before. Vitamin D can prevent falls. Vitamin D can prevent this or that. And with longer studies, with larger studies, this did not pan out to be true. I think the Israeli data is preliminary and not conclusive of anything. It's suggestive, right? So we need larger studies to evaluate that. We have to look at people who get it versus people who don't get it, and it should be a standard dosage, things like that. To that are not that may not include bias. A lot of studies may be, people who are going to the studies are people who are feeling well to start with, and their disease will take a long time to need treatment to start with, and they just happen to be on that study because they are on active surveillance and they're taking vitamin D, and hey, it took a long time for you to have your disease treated in comparison to the general CLL population. I mean, you have to take all comers to look into that, right? Not only people. So there's inclusion bias in the studies, there's selection bias in studies. So it's hard to say. Am I against someone taking vitamin D? No, you may be just spending money for nothing sometimes because these vitamins are not cheap. Lots of times, is it gonna stave off how long it's going to take for your CLL to be treated? We don't really know. I mean, I'm not going to say it won't, or I'm going to say it will. We just don't really have a firm answer on that.
I know, like on so many other things, right? It's just it's what you know. So we talked a little bit, well, probably a lot of it over time, COVID, the boosters and everything else, but what are your thoughts on PEMGARDA? Is that formulated to protect people from the latest variants, and how much protection does it give to us? Maybe explain what PEMGARDA is for those who don't know.
Yeah, Prognostic is a pre-exposure prophylaxis, and people can take that, particularly if they have higher risk, and it's supposed to decrease this more than anything, decrease the severity of symptoms if you contract COVID. It's an antibody. The way it was designed for previous variants. It was approved much earlier in the year. It took some time for it to be priced. It took some time for hospital systems, for instance, to kind of pick it up, have it on formulary and things like that. COVID is ever changing. The variants are mutating quickly. Every couple of months we have a new variant. I am not a COVID expert by any means. My understanding is that PEMGARDA does not cover the current variants right now. On this event that you said on December 13, some things like that will be discussed. So it's a good idea if people have questions to log into that. It's how much protection it gives. It's hard to say at this point. I mean, with the current variants, and we don't have a lot of data in that. We don't have a lot of data, particularly for CLL patients. The studies were larger than that. So these again are questions I get in the office all the time. I cannot tell how much protection you're going to have from this. I mean, are you an untreated patient? Are you a patient who is in third line of therapy? Is your disease how long you have? What's your immunoglobulin levels? I mean, there's so many variants that come into it to predict how protected that's going to be. It's hard. Patients who want to get it, I'm like, okay, I have no problem with it. But I'm not recommending everyone to get it. I say, oh, you have to get it. It's just not there. My take right now is like, my patients who come and they would like to get it. With this discussion, we don't have a lot of data. We review the safety profile, and they're like, I still would like to get it. I'm okay with that. Let's do it. But it's not like something I'm recommending for everyone.
What about I don't know if you say it Enovid or Enovid, the spray out of Israel. Does that truly help you avoid COVID when exposed?
I don't know.
Okay.
I'll be sincere with that. This is not something I have a deep knowledge of.
Yeah, we're as we're running short on time, how about the next few questions? We do like a lightning round. Are you up for it?
Sure.
Uh, okay. If you are on a BTK inhibitor and you get COVID, should you go off of the BTK inhibitor?
No. No, if you don't have severe symptoms, and just a quick thing, this early in COVID, we found out that some patients who BTK actually could be a treatment for COVID. We published a paper on that. I personally had a patient who was intubated with COVID back in 2020, and we gave him full dose of ibrutinib, and the patient was intubated, meaning in mechanical ventilation, and he was out of the ICU within 40 hours after we started the BTK. He had all the other treatments. So this was great. We published that. There were a couple of studies with BTK inhibitors for COVID. There is a interaction between COVID and the inflammasome, which is a molecule that causes inflammation, and BTK inhibits that interaction. So I generally don't stop it unless the patient is severely symptomatic.
Okay. Few questions about what do you think are going to be the hottest studies out of ASH for CLL? Now, I know you and I discussed this, but no one here was privy to that conversation.
I think Amplify will be a good study. I'm biased. I'm a co-author on the study, so
Spoiler alert on that one.
spoiler alert. There's a number of updates on other studies that are coming up. I'm always interested in a lot of the real world data for CLL, in the post-trial world. We're looking at this because, trial patients are highly selected. So we do have a couple of real-world studies on timing of Venetoclax versus BTK inhibitor, for instance. This is one of the studies. Another hot topic right now is the landscape for mutations in the BTK molecule, particularly because pirtobrutinib has been approved, and then we're trying to understand how to sequence those drugs. There's going to be an update, if I'm not mistaken, on BTK degraders. It's still early on. It's still like early phase studies, but there's going to be an update at ASH. Off the top of my head, those are the main studies. I do believe that the larger study in CLL is going to be presented as Amplify at ASH. I know you looked. I'll be sincere. All the abstracts were just released on the day of the election this year, and then I've been going through that, but there was a week I was on service too, so I didn't have time to go over completely over all the abstracts. But off the top of my head, this is the ones I'm looking into. What about you, Michelle? I'm sure you looked into that as well. Is there anything
I
that
have been. Amplify, one of the mutations is huge, I think, for to look at. I do think a lot of the AI stuff is fascinating. I am unsure what I think about them, but that they're actually being given time at ASH to be presented tells me that we really are going light years ahead in using AI. But again, I know they're preliminary studies and they're being presented. So again, my jury's out on that, but there seem to be so many others. Degraders, last year we heard about them. And I look forward to learning how that's progressed in just a year's time, as well as sequencing of drugs. And that's something that we all want to learn about. Is there a magic formula to the sequencing?
I think that's the biggest question we have right now: how to sequence those drugs. Yeah.
Okay, so wow, I cannot believe what time it is. Can we just stay on for a few more hours here, folks? I mean, it's just there is so much here. Someone wrote here, melanoma Nevo vaccine being trialed at Dana-Farber for naive, non-mutated IGVH for CLL. I don't know if that's being presented, or maybe you're telling us being presented. I'll have to check that out.
Oh, they're asking if there are any results. Not that I know.
Okay, great. All right. So as we're starting to close, one last question. Oh, do you use the NCCN guidelines to decide when to start treatment?
I'm just gonna, before I do that, I'm just gonna put a reminder here from Dr. Kaufman, which is very important, that BTKIs may interact with Paxlovid. For people who are asking about COVID before, we talked about Pangarda, but not Paxlovid, which is the post-exposure people who had COVID, contracted COVID, and then to be taken after that to decrease symptoms. Absolutely right. BTKIs interact with that. They need to be held during that treatment. And there are some dose adjustments, if I'm not mistaken. This is my pharmacist; they take care of that. But there is an interaction there, so be careful with that if you're on BTKI and taking COVID. They're asking if I use the NCCN guidelines to decide when to start treatment. I use the IWCLL guidelines. The NCCN guidelines reflect that largely, so it's pretty similar. Uh, 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 the NCCN guidelines are suggestions more than anything else. They're broad. The IWCLL is a little more specific on they're just looking at that. I mean, it's a little different. But yes, what the NCCN guidelines say, it's fair.
And as someone who had COVID for quite a while, about a year ago, I was on Paxlovid and taken off a BTK inhibitor during it, and things improved more quickly.
Good.
So I'm proof of that it does work when they take.
That works. Yeah. Yeah, no, Paxlovid, I'm all for. I mean, Paxlovid is more clear than Pangarda for sure. I mean, our patients have COVID, we generally do that. We use Paxlovid.
Well, doctor, as we're coming to a close, what are your closing thoughts for our audience on the landscape of what's ahead of us with CLL?
Okay. Uh, Well, first of all, thank you for the CLL Society and Michelle for the wonderful work that you all do. I mean, it's great to be able to have this channel of communication with patients and advocates, and give our thoughts outside of a clinical setting, with my Rolling Stones song on top of my head. So thank you for the invitation. I think CLL went a long way over the past decade. This year marks 10 years since ibrutinib was approved for CLL, was in 2014. That just coincidentally started when I became the director of CLL, my previous institution, right before ibrutinib was approved. And I was like, oh, okay, things seem to be changing. Because up to that time, all we had was chemo. We are at a point in CLL where most patients who will be diagnosed with CLL today, they should have the same life expectancy that people their age who don't have CLL. So I think that says a lot, right? It says a lot where we came to, it says a lot where we stand. It is, it became truly a chronic disease. So every time I'm discussing it's like, you have hypertension, diabetes, or diseases that can have more effect on your health than CLL today. I mean, it is a cancer. It's a chronic disease. We have many good treatments for it. Unfortunately, a percentage of patients will have more aggressive courses or transformation, things like that. Fortunately, it's a minority of people presenting with this, but people diagnosed today are expected to have the same life expectancy at their counterparts who don't have CLL, which is great. Now, we always went aiming for a cure. I know we only have 2 minutes here. Hopefully, we'll be able to get to that. We're looking into novel combinations, novel medications, cellular therapy, bispecific antibodies, BTK degraders. I do firmly believe that not during my lifetime, but during the extent of my career, because I do hope to retire someday, that we will be able to cure CLL. I do believe that firmly. I think we're very close to it. I think the future is very bright. I think the newer combinations, particularly combination of BTKI and in Venetoclax are tremendously promising, to the point where we can put most patients on it and have a long-term control of disease with a fixed duration therapy, right? Or there's what we call MRD guided therapy coming down the road. That's what we're studying right now, if when to stop treatment based on MRD. And I think that's really changing the landscape for CLL, and we're going to have more patients with controlled disease not on treatment. That's the goal. So we'll
Those
get
are,
there.
amen to that. I'll leave that simple. I'm all for all that you said. And I just would also love to thank the CLL Society for having us join you and be part of this. I am Michele Nadeem-Baker. Thank you for joining us today here. And our next webinar for the CLL Society will be on common infections with CLL prevention and treatment on December 13th. I'm Michele Nadeem-Baker, and thank you for joining us today.
Thank you so much, everyone.